coming up to talk about MIGS and these in-office procedures that we can offer our dry eye patients and ocular surface disease patients. Justin did a wonderful externship, a fellowship at Vance Thompson in ocular surface disease and anterior seg and glaucoma, and decided to join that practice. And since then has just had a phenomenal impact on our profession. I've really learned a lot from Justin over the years, and I've just really enjoyed listening to his lectures. So it's a real honor for me to be able to team up with you, Justin, and I'm looking forward to presenting this with you. So I look forward to giving this talk with you.
Yeah, thanks so much. The feelings are 100% mutual. It's been a joy being able to work with you and actually being fairly close to each other. We're only really about 4 hours apart from one another, even though it seems a lot farther than that. Just honored to be able to be here with Eyes on Dry Eye, and obviously be able to spend it with you. And this should be a fun, 50 minutes or so of talking about, dry eye, MIGS, the mixture of glaucoma and dry eye. So thanks so much. So preservatives are very important, actually, when we think about topical medications. We look at studies, only about 5% of the dose of a drop that gets on the eye gets to the target tissue. And when we're talking about glaucoma drops, it's very important for the medication to get to the target tissue. That's how we lower intraocular pressure. Well, how do they increase that penetration? Well, a lot of these medications use different types of preservatives. And one of those preservatives, of course, is BAK. That's the one that kind of gets the bad rap, and we'll touch on that here in a little bit. But there's other preservatives as well that can get these medications where they need to go in the eye. And so we know from managing a lot of different glaucoma patients that various types of glaucoma drops create various types of issues on the surface of the eye. And these are just an overview of the different glaucoma drops that we use: prostaglandin analogs, carbonic anhydrase inhibitors, brimonidine, timolol, the new drops, rho kinase inhibitors. And all of us in clinical practice have seen this. And we know that with prostaglandins, there's a connection with meibomian gland dysfunction. And we'll touch on that here in a little bit. We know that with rho kinase inhibitors, very efficacious medications, no doubt about that, but we run into issues with hyperemia. And so again, it goes back to how do we limit the use of some of these medications, maybe not eliminate them, but decrease that burden of medication use.
I could add real quick too here, Justin, just, one of the things we think about too, of course, is BAK. Sometimes we don't hear enough about pH. And so there are a couple of drops out there early on too. I was like, why is everybody so, the BAK is not really very high in these two specific drops, but pH is another thing that sometimes can, cause some of that, sort of intolerance to some of these drops.
That's a great point. And absorption, right? A low pH or something that's acidic, you don't get as well of an absorption into the cornea. So it's not going to be as efficacious. So you're dealing with tolerability and you're dealing with, efficacy when you have that. So I'm really glad you brought that up. So let's talk about BAK a little bit, look at some of the studies, kind of lay the groundwork of why maybe some of these medications create some of the issues that we see in our glaucoma patients. And again, what you're going to see as a trend as we get into some of the other studies is the longer they're on the drop, or the more drops they're on, 2 versus 1 or 3 versus 1, the more issues that kind of will pop up. This was an interesting study published in 2012 in Investigative Ophthalmology and Visual Science. And it looked at BAK 0.01% versus 0.1% versus sterile saline versus a control eye or untreated eye. So the top image here is the untreated, the middle image here, BSS or sterile saline, 0.01% BAK and 0.1% BAK. And this is at day 0. And then you slide over to the right here and you can see at day 7, the BAK group having this punctate epithelial keratitis, the control group and the sterile saline cornea is still looking very clear. You slide over to the left side here, nerve fiber density matters. We think about that. If the nerve fiber density decreases, patients lose sensitivity to the cornea. That leads to breakdown of the epithelial cells. That leads to, you get these kind of punctate epithelial keratises. You get a whole slew of other problems. But if you look at this, the BAK group having a decreased nerve fiber density in this particular study. And then over here with the phenol red test, really a decrease in aqueous production or tear breakup time being worse in that BAK group versus the untreated group or the BSS group. And so BAK creating some problems on that corneal surface. This was a study published in 2013 looking at 3 different groups. You had a control group. You had group 1, which was on only 1 glaucoma medication. Some were on preservative-free drugs, some were on preserved drugs. You had group 2, which was on 2 medications, and you had group 3, which was on 3 medications. 80 total patients in this study. Group 1 had about 30 patients, group 2 had about 23 patients, and group 3 had about 27 patients, roughly in that kind of range. When you look at this, the OSDI score, so symptomology, you can see here that as the medications increased, meaning the more medications that were being utilized, the OSDI score went up. Patients were more symptomatic. Interestingly, if they were on preserved drugs versus preservative-free drugs, much more or better tolerated, less symptomology. Tear breakup time got worse the more drugs that they were on or more drops that they were taking. Schirmer scores worse. Corneal staining higher or worse the more medication these patients were on. And then meibomian glands affected as well, the more medications that these patients were on. This was a cross-sectional study published in 2012. Interesting because one eye was treated with the glaucoma medication, one eye was the control eye. These patients were on the medication for nearly 8 years, 31 eyes in the study. 8 of these patients were on prostaglandins, around 6 or 7 or so were on beta blockers, and then around 6 or 7 or so were on a combination of whatever it may be. They were on 2 medications. It could have been a beta blocker, timolol, beta blocker, brimonidine, whatever it may be. They were on multiple medications. In the control eye, really no major issues. In the eye that was on the medications, you saw lid margin abnormalities, you saw punctate epithelial keratitis, you saw meibomian gland dropout, you saw decreased tear breakup time, and you saw a decreased Schirmer score. So again, showing that multiple medications or glaucoma medications in general affect meibomian glands, affect all the other things we care about with dry eye. This is a study by Fechner looking at symptomology. So this was the OSDI. When we see the OSDI index here, they looked at 630 patients. So a very large study, big group of patients. Patients that were on more medications typically had a worse OSDI. You can see that in the bottom right corner there. You can see over 20% of patients fell into that mild symptomology. Over 12 to 15% fell in that moderate, and then severe group was about the same as the moderate, somewhere between that 12 to 15% or so, having that severe OSDI score. So we know there's a correlation to the number of medications they're on. We know there's a correlation to how long they're on it as well. I know we're throwing a lot of studies at you, but I think it's important to kind of lay the groundwork that this stuff exists out there. This is a study by Weinreb and his group. 101 treated eyes with glaucoma ocular hypertension. 59% of these patients in his study had symptoms of OSDI. And again, that correlation, the more drops they're on, you can see patients on 3 BAK drops, 68% of those patients having symptomology versus a patient that's on 1 BAK drop really being at about 50% with symptomology.
And so that last one, I was just kind of looking through our, I really thought about this one, reminds me of when I prescribe a combination drop and the patient goes and they, come back for their pressure check. And a lot of the times they're on now 2 different drops. I think about that because, sometimes these combination drops have a lower percentage of BAK. Now they're putting 2 different constituents in their eyes and the BAK goes up. So that's another thing, again, it's such a pertinent study with, correlating the increase in symptoms and how many or the concentration of that BAK.
Yeah, combo agents, more, good IOP lowering, but you're another great point. You're decreasing that BAK concentration instead of having multiple bottles of medication. So, I could ask you this question, Ahmad. I think you would, why should we care about ocular surface in glaucoma? Why does it really matter? And we're going to prove it here with another couple studies, because it's very easy to focus on vision loss with glaucoma and forget about the ocular surface. And I know you're in a practice that focuses a ton on the ocular surface, but if I throw this question at you, what's kind of the first thing that comes to mind to you is why should we care as optometrists about ocular surface disease and glaucoma?
We see so many of these patients. They kind of walk in and out of our practices, and if you swing the pendulum basically kind of too far into, one bucket, or kind of pay attention to one thing and not the other, you're really not fully treating that patient. So a well-controlled patient really now, that has to be defined by not just their target pressure, but also their ocular surface. So you get, better compliance, better quality of life. All these things really start to kind of fall together, or kind of come together when you think of treating both of these things simultaneously.
Yeah, that first patient, I can't recall if I mentioned this, but the first patient when we kicked off the lecture today, you saw his eyes, you saw how uncomfortable it was. The funny thing is he wasn't progressing. He's a stable patient. We have other issues to deal with, and we're going to touch on that. That's a stable patient, stable visual field, stable OCT, well-controlled IOP, but there's other issues there that I know you and I are going to get into here in a little bit. There's treatment challenges, right? Why we should care is, number one, it makes it harder on us as doctors to manage glaucoma if our patients are suffering or non-adherent. The study on the left, the Nordstrom study, looking at patients and how adherent they are to their glaucoma medications. You can see prostaglandin, something that's taken once a day, the most commonly prescribed glaucoma medication by us as eye care providers. By 6 months, 50% of those patients had discontinued the drops. You look at alpha agonists, CAIs, beta blockers, things are dosed more often, meaning they have to take them twice a day or sometimes 3 times a day. Compliance and non-adherence even worse, even dropping off the table even more so. At 6 months, you can see there that they're well under 40%, a lot of them even under 30 or 20%, just not even taking them. 90% non-adherent by 36 months with these medications. The study on the right, to me, even more important and more telling. So in the dark boxes, you have patients that are not suffering from ocular side effects from their topical glaucoma medications. In the white boxes, you have patients that are suffering from ocular side effects from their topical glaucoma medications. Follow these patients for an extended period of time, as you can see here. And what we're looking at is visual field progression over time. Now, in the black box, is there progression occurring? Yes, it's glaucoma. Glaucoma is a progressive disease. Even when we're doing our best, it's still progressing. It's still getting worse. But in the white box, you can see those patients that are having side effects progressing at a much more rapid rate than the group in the black box. And what you said a minute ago, Matt, is so important that, yes, we care about vision loss, but there's another piece to this. How do we minimize the side effects? And a lot of times it has to do with ocular surface disease in these patients that are on multiple glaucoma medications. How often do you see these things walk into your practice, these quotes?
Yeah, I mean, there's not a day probably that goes by that, the majority of my patients have ocular surface disease, and I'm increasingly seeing more and more glaucoma in my clinic. I love this slide because it really personalizes everything that we go through, kind of thinking about the patient as, what happens to them after they kind of walk out of your door. Are they able to go to their kids' baseball game and enjoy being a part of these things? And that's something that it's exciting now. Actually, we have better treatment options for these patients. But yeah, these quotes here are just, this is what we see on a daily basis. So it's important to kind of think about the rationale for what you're prescribing, and also keep these quotes like this in your mind about the impact that the impact you're having on the quality of life on these patients when you're really paying attention to both of these things together. It's really important to them.
So what can we do about it? How can we help these patients? So we laid the foundation. We said, there's studies showing that this is an issue and we have to address it. We can't ignore it. And that's all fine and great. And thanks for telling us that. But the question then is, well, what can I do about it? What can I do in clinic about it? Are there options to help my patients? And there's a lot of them. One option, preservative-free formulations. There's glaucoma drops out there that are preservative-free. And this is a study looking at patients that were on preservative drops at visit 1. Then they switched them to non-preserved or preservative-free glaucoma medications. And you can see the drastic decrease in percentages of discomfort upon installation. Patients having signs of blepharitis, the decrease in conjunctival issues, the decrease in corneal staining, drastic decreases in those different things just by making the switch from a preserved topical glaucoma medication to a non-preserve. So that's one easy solution. Selective laser trabeculoplasty, something that I utilize a ton. And honestly, if I had glaucoma where I'm at in my life right now and someone asked me what would I want done for a treatment, I'd probably lean towards SLT in that point, at this point in my life. I know eventually I probably need some type of topical glaucoma drop, but I like the idea of SLT mainly because of some of the studies that have come out in regards to this, specifically the light study. You know, if I can just summarize this study, large study, over 700 patients in this particular study. And the key take home from it was at 3 years, 78.2% of patients were drop free. They compared this against meds, and meds did a great job at lowering pressure. But at 3 years, 78% of these patients not taking a drop by undergoing SLT. And we got to remember, glaucoma is a marathon. It's not a sprint. If we can buy our patients time away from drops for a little bit, then let's try that. It's going to help their ocular surface. It's going to help compliance. It's going to help less progression. And SLT is a good option to consider for our patients. Do you offer SLT quite often, Ahmad, to your patients for glaucoma treatment?
Yeah, absolutely. You know, a lot of these patients, you know, I'm, you know, tune into what's happening on the ocular surface if they have, you know, blepharitis, mild meibomian gland dysfunction. And even without any of these findings, really the first thing in my mind is, you know, SLT, you know, treatment. So my threshold to, you know, because of this study and many others, I mean, if I'm a patient and this is not even discussed with me as a new, you know, patient going through a new diagnosis, I'd be a little bit upset. I mean, this is really a great treatment option, should be offered and discussed at least every, you know, anytime, you know, every time you have one of these early glaucoma patients. You know, one of the things that kind of didn't make much sense to me when I first read this is how could there be no difference in, you know, no significant difference in quality of life.
Yeah.
But after I kind of looked through it a little bit, that the authors felt like the questionnaire that was being used wasn't really very glaucoma specific. So it'll be interesting to see what's gonna, the follow-up to this will probably demonstrate something different as far as, you know, different, you know, measuring the impact on the quality of life.
Yeah. And, you know, this study, again, if you look at the stats and the conclusion there, we found out as well that medications work very well still. It's just, to your point, we have an oath to talk to our patients about all their options and help them drive the bus a bit. And some of them need us to make the decision for them and tell them what we would do. Some would like to be involved in the decision. And so for me, talking about meds, SLT, and even what we're going to get into here, glaucoma drug delivery is very important. They need to know these things are available to them. And this is just an overview right now of all the different glaucoma drug delivery devices and procedures that are being looked at in the market today. And really right now, we just have one on the market that we're utilizing. That's called Bimatoprost SR, which that's what we're going to jump into. But this is an exciting arena. And if you ask me, what am I most excited about for glaucoma treatment right now? I would tell you it's probably glaucoma drug delivery. I think it has the ability to be an adjunct to a lot of the therapies we're using right now. It may take the place of some of the therapies we're using right now. I don't anticipate it's going to eliminate drops or eliminate surgical procedures, but it's nice to have another option to use in our toolbox for certain situations. And we're going to share a couple of those situations here in a second. So Bimatoprost SR, this is FDA approved now. This is a 10 microgram Bimatoprost sustained release implant. In our practice, we actually do this at the slit lamp. We don't do it in a small procedures room. We don't do it in the OR. The implant is within a needle. You can see the device down on the bottom right there. We give the patient a drop of proparacaine. Obviously, they feel a little bit better when the procedure is being done. And then we do a betadine wash to protect against any type of infection. Have never had a case of endophthalmitis with it. We've done at least 100 of these in our practice. And I'll tell you too, that in the FDA clinical trial, the phase 3 clinical trial, no cases of endophthalmitis as well. It's a biodegradable implant. It releases Bimatoprost. What's fascinating about this amount is 10 micrograms of Bimatoprost is essentially equal to one drop of Bimatoprost in a bottle. That's all it is. And you can get IOP lowering from this out to 6 months, 12 months, 24 months. I'll show you that here in a phase 2 clinical trial next. It varies a little bit from patient to patient, obviously. Technically, the pellet's releasing medication for 4 months, though. That's how long medication is being released from the pellet. And right now, FDA approval for it is we can only implant one of these. And so we can't go back in and put another one. And so I'm going to ask you the question in a minute, but a common question that comes up to me is, well, why would I ever want to use it then if I can only place one of these? and never be able to place another one. You just said, Justin, that glaucoma is a marathon. It's not a sprint. Why are we using something like this that can only really lower pressure for a short amount of time? But pause on that question till we get to the end. So this is how it's done. Done at the slit lamp. Patient's been given a drop of piperacane. We've already done a betadine wash. Typically, they'll penetrate the cornea from the temporal side. And as you watch here, when he releases the pellet, it does come out very quickly. It'll drift right down to the inferior angle. As aqueous penetrates that pellet, it'll become a little bit sticky. And so I've never seen one kind of migrate a long ways away. They might be a little bit temporal, a little bit nasal, but typically in that inferior angle. And that's the procedure. It's that short, it's that quick. What about MIGS? I think that's really what we want to get to. And we want to talk about, minimally invasive glaucoma procedures, how they work. This is an anatomical view of what's going on with the angle of the eye. We think about it. Schlemm's canal goes 360 degrees around. Right over here, we have the trabecular meshwork, which sits right, in front of that. And then behind Schlemm's canal are all these different veins and collector channels where the aqueous flows to. And in glaucoma, we know there's something going on. We know there's something wrong with those collector channels, or excuse me, with the trabecular meshwork. And we really want to access Schlemm's canals. We really want to access those collector channels. And that's really where minimally invasive glaucoma procedures can help us. But really the best part about MIGS is, yeah, it can lower pressure. It's not going to lower pressure as effectively as a tube shunt or a trab. But when you look at a lot of the different clinical trials, Tom Samuelson very well. You work with him on a consistent basis. He's led some of these clinical trials. He led the Horizon trial, which was the FDA clinical trial for one of these Schlemm's canal microstents. He led the clinical trial as well, or was part of the clinical trial for these trabecular micro bypass stents. And in both of these clinical trials, IOP lowering occurred. But look at the IOP, or look at the medication reduction. And I think that's a key thing. A reduction in medications. Didn't get them completely off meds, but we see a reduction of medications. Another procedure where we're actually removing an ab internal viscocanalostomy, ab internal trabeculotomy. It's got a long name to it, but we're removing the trabecular meshwork, opening up the canal. And again, you're seeing a reduction in medication as well as a reduction in IOP. I want to share a new study. This is a canaloplasty and trabeculotomy study looking at patients that were pseudophakic with open angle glaucoma. These patients were on medications. This is called the Romeo study. Two groups. We had a high baseline group and we have a low baseline group. The high baseline group had IOP lower of about 29% over a 12-month period. More importantly to me, that 29% is great. We lowered IOP with it, but they went from they got off of more than a half glaucoma medication. So they actually went down from a mean average to a 0.7 glaucoma medications. That's how much they got off of, to be clear. The lower baseline group, not as much IOP lowering, only about a 10% reduction in IOP in that circle group, in this group right here. But they got off just as many medications as this particular group. So a mean average of reduction of 0.7 glaucoma medications. And so you're making an impact in a few different ways. You're making an impact in lowering their pressure, and you're making an impact of getting them off of medications, which naturally you would think would help their ocular surface. This is a great video really showing what MIGS procedures do based on the anatomy. So what you're seeing here is aqueous angiography, a patient pre-stent implantation and post. So before is on the left, and you can see there's an area of aqueous collector channels right here that there is flow into it, but there's a lot of areas where it's dormant. The collector channels aren't allowing aqueous to flow into, and the trabecular meshwork isn't allowing it. And I'll play that again really quickly here. On the other side, what you see is two stents being placed and all the flow of aqueous into those collector channels. And to me, this is the holy grail of MIGS procedures. If there's a way that we can do this very non-invasively, very quickly in the operating room, our surgeons can do this, and they could target where they're going to put these MIGS procedures. They're going to be much more effective at lowering intraocular pressure, more effective than they really already are. And they're pretty effective right now, in my opinion. So I mentioned earlier, we think by reducing medications with MIGS, by taking patients on 1 drop down to 0 or 2 to 1, that it should help our patients to make their ocular surface disease better, but no one had really studied that. And so myself, one of our good colleagues, Whitney Hauser, Ahmad, very good friend of yours as well, good friend of ours, Dr. Mitch Eibach, and then some of the surgeons that I work with decided to look at this. We wanted to say, well, no one's looked at this. Let's look at patients that are going to undergo cataract surgery plus a MIGS procedure. Let's have them take an OSDI. Let's check symptomology on the front end. Let's have them undergo surgery. Let's monitor them for 3 months. And let's have them take it on the back end. And then let's look at corneal staining. Let's look at conjunctival hyperemia. Let's look at tear breakup time. And let's see if truly doing a MIGS and decreasing the amount of medication usage will help their ocular surface. And so we did this, a very small pilot study, 50 eyes in this particular study, followed them for 3 months. I mentioned all the different measures we did. And you can see their preoperative OSDI was at 40.1. That falls in that severe range. Remember, with the OSDI, 33 to 100 would be considered severe. 0 to 12 would be considered normal. 13 to 22 is considered mild. And then 23 to 32 would be considered moderate. These patients fell into that 40 range. When we look at them post-operatively or 3 months later, they went from 40.1 down to 17.4. They didn't go to normal, but they went to mild. So a great or significant improvement in their symptomology. So symptoms improved. This is, again, just after cataract surgery plus a stent. These patients went from around 1.4 glaucoma medications down to about a half. So we almost got them off of about a bottle of medication at 3 months undergoing cataract surgery plus a MIGS procedure. Corneal staining, significant decrease, really about a 3-fold decrease in corneal staining preoperatively to postoperatively. Tear breakup time went up from 4.3 to 6.4, and this is an average again, or a mean. So a nice improvement in tear breakup time as well. And so I'm going to pause there, Ahmad. I'm sorry I jumped ahead there, but I know you want to spend just a brief or a few minutes talking about this. We theoretically always think, well, MIGS, decrease meds, it's going to make them better. I would love for someone, maybe you, to do a large study, more than 50 eyes on something like this, because I think there's something to be said that we would agree that MIGS procedures decrease medication burden, which should overall help the ocular surface. Am I correct in saying that?
Absolutely. Yeah, absolutely. And I love that a highlight of your study was really looking at OSDI and tear breakup, because those are two things that I just think, I mean, if a clinical study that's really well done can show some improvement in both of these things, in my experience, that's what really translates to improvement in their quality of life. That tear breakup time is so pivotal that even a little bit of an improvement there, that really, in my experience, really correlates to those patients just feeling better. And having these OSDIs, I think one of the nicest things about them is that it really helps with the patient psychology of having these things too, because when you're showing them that at some point you were really not doing very well, look at how far along you've come, that really is impactful. Their overall kind of how good they're feeling about their progress is really important too. So yeah, absolutely, really a neat study, and very well done.
Incomplete blinks, looking at floppy eyelid syndrome, a test that I do quite often is I'm worried, are patients closing their eyes all the way at night? Do we have some leg ophthalmos? So I do a test quite often in my glaucoma patients called, the core Blackie light test, where you take a muscle light, you have them sit back in the chair, close their eyes. I tell them just gently rest your eyes like you would if you're going to fall asleep. And I, put the light right above the tarsal plate. And if I can see a bunch of light sneaking out the bottom, I know that they're probably not closing their lids all the way. And so that's going to exacerbate ocular surface disease. And we have to treat that. So what about in-office procedures? I'm going to go through these fairly quickly, but I think it's worth touching on them, right? We want to treat meibomian gland dysfunction. We've treated meibomian gland dysfunction for a long time with nutraceuticals, or we've said, hey, do some warm compresses. And I don't think warm compresses should go away. Still utilize them actually all the time as kind of an adjunct to a lot of the in-office procedures that we're going to talk about right now. And I'm a fan of these in-office procedures, and I utilize many of them, but one is thermal pulsation, where the glands are being heated and they're being massaged so that glands are being expressed. And this happens for about 15 minutes. There's also external application of heat and then manual expression. And so this is another technique that I do quite often in my practice as well. And I've had a ton of success with it as well. And not only have I had success, but there's studies supporting the success of both these different types of procedures. Now, this is the Olympia study really comparing thermal pulsation versus this external heat and manual expression and how effective both of them are. You can see here looking at just tear breakup time, the blue and the red, both those treatments that I just mentioned, very effective at increasing tear breakup time. And to your point, Ahmad, if you can increase their tear breakup time, make that better, the patient's going to be less symptomatic. They're going to feel better because we're making them better by keeping more tears in the eye, a healthier tear film, better meibomian gland function as well. Here you can see that the meibomian gland secretion score better with both groups. Both of those devices we just looked at, improving the meibomian glands, making the meibomian glands healthier and allowing these patients to very likely be less symptomatic and feeling better. Another kind of handheld thermal pulsation treatment where it's using some light, it's using manual expression. You're able to control the force and express both the upper and lower meibomian glands while applying some heat. Again, doing treatment in that situation, very similar to what we talked about with the other two treatments. This study comparing these two different types of thermal pulsations, the one we talked about initially, and then the one that we just showed you here a second ago. Again, you look at the OSDI score, making patients less symptomatic. You can see at 2 and 4 weeks, both treatment options working very well. You can see tear breakup time, again, improving, getting better, meaning less symptomology. And then again, the meibomian glands improving as well with both those types of thermal pulsation technology. So these in-office procedures work very well. You can't just take that from me only. You could have to look at the data as well. And the data has proven that with a couple different studies that I show you here. So Ahmad, I'm going to turn it over to you to cover a few other things in regards to meibomian gland dysfunction and some other options for patients that are suffering, with meibomian gland dysfunction in our glaucoma patient population.
So, I mean, I'm sure a lot of our colleagues that are listening in right now, we have known from other clinical studies that the majority of our ocular surface disease patients have some kind of a contribution to their disease due to meibomian gland dysfunction. And so if we really want to focus on one thing that is most likely going to get these patients better, it's really the meibomian glands. And I've learned so much from the folks that have really dedicated, frankly, their life to studying the meibomian glands, Dr. Don Korb and many others that have, learned from him. One of the things I learned from him is non-obvious versus obvious meibomian gland dysfunction. And, we have to kind of think about where is this obstruction? On some glands, it's going to be more distal or closer to the lid margin. And on other glands, it might be a little bit farther down the central duct. And so our goal is just to get these little pockets where all these acini that are producing the meibum to be producing healthy meibum and getting them from the more proximal parts of the gland all the way through the distal part and onto the ocular surface. And so I think about that, just like that anatomy slide on earlier in our presentation, I kind of try to think about that when I'm looking at the slit lamp, not just, kind of pressing on the glands and saying yes or no, but try to look a little bit more carefully into, kind of the anatomy of the gland and whether there might be an obstruction that is more superficial or more distal. And so because of that, I've found that using, very, kind of selective meibomian gland probing with the 1 millimeter probe has been very helpful in those glands where there's some kind of an obstruction there that is more distal. And so this is a 1 millimeter probe that I'm using to break a very superficial obstruction. And sometimes that is just really hardened and stagnant meibum. And sometimes there's some scarring, some external obstruction there. And I found that just putting pressure on something like that with a forceps sometimes really isn't the best thing. And it's really not going to help that gland ultimately get cleared. If we have a known obstruction there that is not getting cleared just by pressing on it, sometimes using a 1 millimeter probe, in my experience, has been very helpful. If you can pause it there, please, Justin. So this was a really impactful thing, if you can see that central gland, how it's coming out, that meibum is coming out much more different in quality compared to the neighboring glands. You can see that filamentous secretion. That to me means it's been sitting there a lot longer. And when you do expression on some of these glands and you go back and forth along the lid margin, and some of these glands have neighboring glands that are producing some oil and some that are just not producing any, sometimes just pressing on it with an eyelid forceps might not be enough. So doing kind of selective meibomian gland probing, I've found that to be very helpful in getting these obstructions released and getting some of our meibomian glands to deliver healthier oil to the surface.
That's an impressive video. Really, really impressive.
Thanks. Yeah, and so, kind of zooming out a little bit and thinking about, okay, well, what is the neighborhood that all these glands live in? If it looks like this, a lot of telangiectasia you can see in this picture, and then those whiter spots, you can see those are actually more fibrosed endings of these meibomian glands. So this is a patient, and you can see a little bit of a notch there. It's a little bit tough to see that, but there's a little bit of a notch where if you pull down on that lid, you can probably see more cicatricial types of changes to the glands.
Right in this area, is that accurate?
Yeah, exactly. That's exactly it. Yep. And so, kind of looking at how inflamed that lid margin is without a doubt impacting the quality of the meibum and the health of those glands. And so this is where that IPL has been a really an important part of my ocular surface disease clinic. This was a clinical study way back in 2005 that looked at these patients, having much better, decrease in the telangiectasia for the treatment of their rosacea. And it was Rolando Toyos, who's an ophthalmologist, that really pioneered, kind of how this can be applied to improve those same telangiectatic vessels that were on that last slide in an effort to improve ocular surface disease and meibomian gland dysfunction. And so this has been really helpful for my patients that have blepharitis and other dermatological, problems with, along with that, like rosacea. So these patients usually do improve, this telangiectatic vessels improve. And I find that to be helpful to kind of do these thermal pulsation, types of treatments in combination with IPL in a lot of these patients. All right, so Justin, you laid down the foundation, really a very, very strong case for, MIGS are effective. In-office treatments are also very effective in improving meibomian gland dysfunction. So how does this, first of all, I want to ask you a quick, which thing happened first? Are we talking about, in the majority of these patients, is this all, a lot of this just iatrogenic ocular surface disease or dry eye, or, are we causing dry eye in glaucoma patients, and that's what's really going on here? Which came first? And then the second part of my question will be, what's on the slide here? What should we be offering to these patients and when?
Yeah, I think we're not intentionally causing or trying to cause dry eye in patients. We know that dry eye in general is very prevalent in the population, whether it's glaucoma or not glaucoma. The issue is with some of the medications that we use, we're going to exacerbate something that may have already been there or they were predisposed to anyways. And so they may be getting in. Remember, our glaucoma patients are typically of the older age where we see more dry. And so it's just a combination of all those things that can create it. So none of us are intentionally trying to create these issues, but they just go hand in hand because of all the studies that we just talked about, the multiple medications, the preservatives that can affect that. And so that exists, and it's going to continue to exist. How do we treat this stuff? We know MIGS is effective. I will tell you, I would treat the dryness, the ocular surface disease first before I send patients in for surgery. Yeah, MIGS is going to get them off of medications, and that's been proven in multiple studies, but I want to aggressively treat the surface first before I have a patient undergo any type of ocular surgery. And so what should we use? We should use all the things we talked about. You mentioned it. You pair together IPL and a lot of those in-office procedures like thermal pulsation or external heating and gland expression or gland clearing. So I think those are all very useful. We should still utilize, our immunomodulators. We should utilize, when there's not a ton of inflammation, punctal plugs. and I'm getting the weeds a little bit, but we even use anti-inflammatory agents. Corticosteroids can be helpful. So I think the key is we have to treat the surface first, get that as much under control as possible before we send them to have, for example, a MIGS procedure. And that treatment may involve a drug delivery procedure to get them off a med to treat the surface and then send them for that MIGS procedure. So that's how I would handle it.
That's perfect. I mean, that's exactly, I mean, I would, on the more severe end of the spectrum too, one of the things I try to remind myself on those patients that just come in and they're always a little bit hot, their conj is always a little bit inflamed. Keep in mind, if that patient progresses and needs to have a trab, the success of that trab will likely be dependent on, controlling that inflammation. So, even though these patients might come in and they look, like there's obvious inflammation there, if they're not very symptomatic, sometimes I'll still treat the ocular surface side of things more aggressively than maybe their symptoms might correlate with, just because they're a glaucoma patient. They might have a long road ahead of them here.
Completely agree.
Yeah.
In conclusion, this patient right here, this is a patient that obviously has glaucoma. I don't think any of us would argue there's glaucoma here. They have visual field defects. They have, retinal nerve fiber layer thinning. And then you take a look at their eye, they have an incomplete blink. They have a tear breakup time that isn't good. They have punctate epithelial keratitis. And the argument I would have here is, and I would ask you this, Ahmad, is the glaucoma really the issue here? It's an issue, but is it really affecting their quality of life?
Right. So this is actually a guy that was really symptomatic because of the tear film. So he's this, truck driver, and he was referred for his ocular surface, and this was discovered after that. And so 100%, I mean, I love presenting with you, Justin, because you got this right away. This patient is much more symptomatic from the dry eye, and that tear film, as you saw on that last slide, that just keeps breaking up as soon as he opens his eyes, and he didn't even know he had glaucoma. So again, it just, underscores the point that both of these things have to be really carefully evaluated. The patient does have glaucoma, but also never lose track of what's really driving a lot of his symptoms.
Yeah, he's seeing just fine. His visual field defects are there. They're not in the central portion of his vision. He's seeing just fine. What's affecting his life is very likely what you're seeing on this slide here. And so we have to balance that and make sure that we're using all the tools in the toolbox. Here's our patient we saw earlier. We know MIGS can be helpful. We know drug delivery can be helpful. We know all those in-office procedures we talked about can be helpful. And like this patient, he's a well-controlled glaucoma patient. He's not progressing in front of me right now, but he's suffering for a variety of other reasons that are occurring. And if I don't help him, then I don't feel like I'm doing my job. I've done the job of stopping or slowing down the glaucoma, but I'm not doing a good job of allowing him to live a high quality of life because of the way that his eyes are looking. So I want to thank you for having me to be, Ahmad, part of Eyes on Dry Eye, and to the Eyes on Dry Eye team for letting me do this with you. It's always a pleasure. I learned so much from you, and an honor. So thank you.
Likewise. Thank you so much for doing this. And I look forward to working together on other things. And hopefully this has been helpful for all of our colleagues. Thanks so much, Justin. And I love that study that you shared that talked about morphological changes that we can actually see in the meibomian glands on these patients and how that correlates to the number of medications they're taking. And it just really stresses the point that meibomian gland assessment, especially on the glaucoma patient, is really something that you ought to be focused on in these patients. One other thing I kind of wanted to, just kind of bring up too, what do you think about, I mean, a lot, sometimes these patients that we really need more than one eye drop to, preserve their vision and keep them in that target pressure. They also, in your gut feeling, you're like, okay, these patients really deserve to at least have the option of having an in-office ocular surface disease treatment. How do you balance all of that as these patients sometimes have a lot going on?
Yeah, I mean, it's a discussion that you have to have with your patients now that have glaucoma. There's too much data. There's too many studies out there that show that, when you're treating patients with topical medications, there's very likely going to be some type of ocular surface disease component with that. And a lot of times there's going to be MGD along with that. So you have to evaluate the meibomian glands. And I do take time during the evaluation when we're talking about their glaucoma treatment, when I've talked about their visual field, how their OCT looks, is there progression, is there not progression? I talk to them also about what's going on with their lids. I talk to them about their ocular surface, and I talk about a lot of the therapies we mentioned. Thermal pulsation or external heat and manual gland clearing are two that I use often in our practice, and I use them often in glaucoma patients as well. It's not just for patients that have dry eye, it's for my glaucoma patient population, because this happens in that population at a high rate.
Okay, awesome. I was just asked to kind of just restate that first questions. I think we had some trouble with audio. I just want to make sure that we get that part covered. Justin, what options are there available for the patient that's already pseudophakic as far as having the potential to have a MIGS procedure?
Yeah, so we have standalone options. It used to be you'd say, boy, MIGS can only be done in conjunction with cataract surgery. That would have been back in 2012. But there's now standalone options that are available as well to kind of reduce that medication burden. Maybe not eliminate medications, but at least reduce the burden, which will equal, as you saw in my study earlier, which will equal less symptomology and more tears and less corneal staining. So all the things we want to see when we're trying to manage dry eye.
Awesome. And I love that that guy that we have this image of this guy in the presentation in the deck, where it's just a telangiectasia, rhinophema, and just he's a lot of times these glaucoma patients just come in visit after visit, just never really looking nice and quiet, and that's really oftentimes what's the main thing that's bothering them, especially as we kind of talked about this earlier, especially if they're on the milder side of the glaucoma. The main thing that's bothering them is really tough ocular surface disease. So keeping that on the in your mind is really important. I have the same thing kind of happens sometimes with my retina patients that need to get injections all the time. The retina docs say to me, hey man, the macula looks a lot better, but these patients are really upset about their dry eye. Ahmad, I want you to help me out with that. So the same thing happens with these, with these glaucoma patients. So any other clinical pearls, Justin, that you'd like to please share with us before we sign off, as far as what have you been, found to be the most important things as far as balancing these two things, and going forward, what are some other things that you might be you're really excited about as we kind of treat ocular surface disease and glaucoma simultaneously?
Yeah, I think, it's very easy to get caught up in glaucoma, worried about vision loss. I mean, that's what we're trying to do, prevent vision loss. And that's a scary thing. But these patients are suffering. That gentleman you just talked about, he wasn't progressing. He wasn't getting worse, but he was not living a very fun life because of the way that his eyes were. So we really have to keep both things in mind when we're doing that. I think from what am I excited about piece of things, I think, there's going to be more MIGS procedures coming that are going to be able to be utilized in different ways, that are going to be able to be utilized in pseudophakic, being able to be utilized in phakic patients. And a lot of times insurance will participate in covering these things. And that's exciting because, again, we're not here, and this lecture isn't about how do we eliminate drops. It's how do we reduce the burden to make sure that our patients can live a good quality of life, that they keep their vision from glaucoma, but that they can spend time with friends, family, out in the world without having red, irritated, or blurry vision.
Awesome. Super job. Great stuff, Justin. As always, thank you so much for this talk, all the other great work that you're doing, and keep it up. I love learning from you, and thanks for all you do. Really appreciate it.
Thanks, Ahmad. Thanks for having me. Had a blast.